Carol can kick off. We can cover anything.
Hello. I've got a quick question, topical of the time of that we're going through, I suppose. If we think that COVID played a part in somebody coming down with ITP, how much do we hold our breath until they have COVID again and then think that actually, because that's what the trigger was originally, then by definition we think that this is going to lead to something because of those pesky memory cells?
Well, that's a good one for Dr. Semple.
Well,
Dr. Semple's the immunology expert. He will explain that to you.
Yeah, I mean, it's possibility, but I doubt, with any viral infection, there's a possibility of getting an immune-like thrombocytopenia. That's been shown. Whether or not when it repeats itself, you get the same thing, I don't know if that's ever been shown. So I think, it's a very rare incident.
And David may want to talk about this because he reviewed it for either last year or the year before, looking at immunisation in general and thrombocytopenia and the likelihood of it recurring following repeats. And this was a particular issue for children with MMR and other things. David, would you like to comment on that?
I think there's a difference between vaccination and frank COVID infection. You talk about COVID-induced ITP, meaning you got COVID, then you got ITP. I think the answer is we've had patients where that situation occurred, they recovered, they got COVID again, didn't get ITP. So I will simply say that my anecdote, which is 3 patients, is that the second infection, and some patients, the third infection, didn't cause the disease to come back. So I don't have any bigger numbers. The data that Jim Bussell put together looking at this also didn't describe this being a continuing event. So I think right now, like many viral infections, it may be a one-off and done, I hope.
And I suspect the position is also massaged a little bit for people who've had multiple injections, the original 2, then 2 or 3, 4 boosters, plus or minus an infection as well, which gives very good cover so that a further infection may not be quite as serious. Now, whether that's then associated with thrombocytopenia or not, as I think almost the toss of a coin, but is less likely to happen.
I think we're in a different era right now. I'm hoping that everyone's been vaccinated or infected. At least that's true in the United States, I think, and it's probably true here as well, that we're a different era. And I think that we ought to recognize that, unlike prior epidemics of H1N1 flu virus from 20 years ago, which did the same thing, that we're now not having that problem recur to any significant extent. I'm certain it's still going to happen, but I think it's going to be much less likely.
And it's a shame in a way that Sue Pavord had to go because she was collecting a lot of the data in the UK. And of course, the situation where you immunise millions of people in a very short period, you're going to show up very rare indications and side effects, which in general you would barely notice in the normal population. I don't know what the later data was, but I know early on looking at the various vaccines, with the AstraZeneca in the first year, it was something like 20 per million were developing thrombocytopenia post-vaccination. With the Pfizer vaccine, it was about 11. Now, we've always said that the incidence of ITP in the normal population is 60 per million. So maybe the vaccination saves you from getting, that's being a bit facetious. But of course, thrombocytopenia post-COVID, particularly as the COVID gets more severe, is much, much higher than that. So sort of the issues that we were debating earlier when Mark was here and about what they do in France and do you immunise people who are very low risk from COVID or very low risk from serious COVID, but are the ones who are likely to get this VITT, the thrombosis, thrombocytopenia, or do you just save it for the older people? I think it's a whole mix, but I think David's right that we're in a really probably a different situation now.
Reality is the fact that thinking of the individual I'm thinking of, they had 3 vaccinations and COVID twice, and then sometime later a low platelet count. So I suppose it is just a big story, isn't it? We can't attribute it to one thing.
I think the answer we know in part from 35 years ago. There was a study published in the Lancet like in 1982 looking at kids that had MMR vaccine and got thrombocytic ITP, and there's a huge peak in the 6 weeks after the vaccination. It came down again, and there's a second publication a decade later where they got given the rest of the MMR vaccine. None of the kids came down with thrombocytopenia again. So I think it's an interesting topic, but I think it's there's less anxiety these days than there was before.
Yeah, I was going to say, in pediatrics, we give lots and lots of vaccines. And so the notion of ITP associated with vaccines comes up, and MMR is the best.
It's the only one where there's
where there's a true kind of enough data to suggest that association. And even in that setting, we recommend that if somebody doesn't have high enough titers, they go ahead, they get a second vaccine. Again, because really, we think consequences of having natural virus far outweigh any small risk of recurrence, and we really haven't seen recurrence. So in a group of heavily vaccinated individuals, we really always favor vaccination continuously.
It's a very interesting point, and of course, a lot of the sort of earth memory of these infections has gone. When I was at school, we always had someone in the class with a caliper from polio. When I did my medical training, not 3 miles from here, there was the Eastern Fever Hospital, where the entire top floor was full of children who'd got encephalopathy post-measles infection. You just don't see that anymore, and I think people have forgotten the severity of what natural viruses and their infections did, and now pick on a very small number of problems post-vaccine. Now, up to point, I think there is a governmental issue here where they should have set up many years ago a no-fault system for post-vaccine damage in the way that they accepted for thalidomide, in a way they're possibly going to accept for valproate now. But it's each individual group is having to fight, and also in the infected blood issue that's going on at the moment, each individual group has to fight for this rather than someone taking an overall view and seizing it and saying, well, we're doing this for public good, we need to accept and deal with the individual outcomes that come from this. And I think no one is prepared yet to bite the bullet and take on the financial consequences of that.
Okay, come on, more questions. Oh, good.
Hi, I'm Maria from Finland. I apologize, my English, it's not my mother tongue. I have 2 questions for you. The first one is that I heard that ITP patients could be in higher risk of thrombopoietic events like thrombosis, even if your platelet count is not that low. And I wonder if that's true or not. And the second question is that I've read a lot about, we call it vagus nerve. Do you know that? VAGUS nerve. That if you stimulate the nerve, it has influence of your immune system. So I'm really curious about that how can it affect the immune system, and does it affect autoimmune diseases in that way?
Gosh, I don't know about the vagus nerve.
John, Dr. Semple, the vagus nerve, this must be...
In the vagus, it innervates the top part of your gastrointestinal act, and the gut has its own immune system that's different from the peripheral immune system. So, I mean, it certainly, I've read reports too where vagal stimulation can change the level of, for example, T helper cells within the GALT, the gut-associated lymphoid system. So yeah, I mean, it's a big nerve. It innervates a lot of things down into your abdomen.
But the thrombosis issue, I don't know, Dave, you want to address?
Well, I think the thrombosis issue, I think is settled. I think, Adrian, you're on that paper, the Saparwati paper, looking at the thrombosis rates, and it turns out as your platelet count gets lower, the thrombosis rate increased. When the platelet count was sort of 50 to 100,000, the thrombosis rate was normal compared to other controls. So I think it's ironic that, it's typical of highly consumptive platelet disorders being ITP, a thing called TTP, and a thing called HUS, which the more you're destroying platelets, the higher the thrombosis rate. So I think it's due to the increased destruction that causes the blood clot. So if you're destroying platelets at a lesser rate, you probably have less of a thrombotic risk, unless you have an underlying condition like our colleague here with the anti-phospholipid antibody syndrome.
But looking at thromboses in ITP per se, there is a slightly increased risk of thrombosis. difference between arterial and venous thromboses, and certainly post-splenectomy venous thromboses are quite common. Arterial thromboses, which are things like myocardial infarction, strokes, that sort of thing, are slightly more common. The more severe ITPs probably have a slightly increased risk than the moderate ITPs. There may be a whole variety of reasons for that. It's possible that the autoantibody itself affects the endothelial cell, which is the lining of blood vessels, that itself can provoke clotting. So there certainly is an increased risk, and it's a sort of misnomer. We always used to think, oh, platelets low, there's no risk here. There clearly is, and you have to consider that in detail. But of course, treating is quite difficult, because if your platelet count is less than 20 and you've had a thrombosis, treating that can be really quite difficult. And it's a balance between the treatment to bring the platelet count up and then adding some sort of anticoagulation.
Which brings up an interesting topic, which is if you have ITP and a platelet count of 20,000, you have a heart attack or having anginal symptoms, there's a reluctance of cardiologists to give you aspirin, which is a typical first therapy before other things are done. Ironically, he should give you twice as much aspirin as someone else, because your platelets are living for aspirin. You ingest, it's in your circulation for 15 minutes, it does its stuff in that 15 minutes, and the drug disappears. Its effect on the platelets will last for the lifespan of the platelet. But if your platelets don't live for 4 hours, you got a brand new cohort of platelets. So if you have a heart attack and you're not bleeding, take all the aspirin you get, because you probably need more than someone else does.
Yes, so it's counterintuitive, but in our practice, in such situations, we'll try to raise the platelet count in order to start anticoagulation or antiplatelet treatment.
I actually think the antiplatelet therapy has depending upon the real reason for it, it varies. But I'm comfortable anticoagulation with, warfarin or Lovenox or things like heparin, anything else like that, at a platelet count of 20,000, as long as you don't have a history of bleeding already. I think that one agent is fine. Was that? Yes. And this has been published by a number of Jeff Zwicker published this 5 years ago.
Yeah. I think we have a question here.
Yeah. It's very quick. I just wonder, how efficacious is penicillin on a daily basis for an ITP patient?
As an ITP therapy or as preventing infection?
Post-splenectomy. You mean post-splenectomy?
Okay.
Yeah, in terms of, you mentioned guidelines. You said, I don't know if the guidelines are right for UK. Do you remember John, somebody who wrote guidelines for the British Society about 20 years ago?
Yes.
John... No, not John. There's another John. And we don't have any current guidelines, do we? Although the chief medical officer recommends penicillin twice a day for life.
Yeah.
In other countries, it's for a short period of time. So we have no current guidelines, do we?
No. You do have the current guidelines, which was from the CMO when Liam Donaldson was there. Yeah. The guidelines previously were you had your immunizations against flu, meningitis, pneumococcus, and then you took penicillin for 3 years, which is the main period, although you have a minor risk of overwhelming infection even 20 years out. But the main risks are in the first 2 or 3 years. But there are certain groups where the risk continues. People, particularly sickle cell disease, who've infarcted their spleen, but in people who are on immune suppression, so an ITP who's on steroids or immune suppressive therapy. But someone with ITP who's had their spleen removed and his platelet count is normal almost certainly doesn't need to take antibiotics for life. And what we do, although it's not, the guidelines don't support this, is we'll often give the patient a supply and say, keep this at home. If you start to get an infection, if your temperature goes up or you produce some green spit, take your antibiotics. Otherwise, you really don't have to. Because there are the issues of long-term tolerance and bacterial insensitivity. So I think it's the balance, and I think the blanket advice, and I think we're one of the few countries in the world that suggests taking it forever. I think that's wrong.
My concern is the gut biome, because I'm taking penicillin daily.
Yeah, and I think as we increasingly understand the importance of the gut biome in general health, I think that's actually quite an important issue.
Earlier, Dr. Cooper talked about, in her session on teens, talked about serotonin and ways to boost serotonin. I believe serotonin is carried on platelets. So if you have a low number of platelets, wouldn't it make sense that ITP patients would have a lot more anxiety and depression, both in teens and adults? And is there any way to overcome that?
Well, serotonin doesn't cross the blood-brain barrier. So although you may have very high levels of serotonin carried in platelets, which you do, and those levels drop when the platelets drop, that doesn't necessarily impact on what's happening within the brain. There are some things you can take that may cross the blood-brain barrier that may enhance serotonin levels, of which I think tryptophan is one. But I think there's not a clear association, although I think we all used to think that that serotonin levels dropping with platelets was why you became fatigued and anxious. I don't think there's that clear-cut association anymore.
Eat turkey. Lots of tryptophan in turkey. That's why you fall asleep after a big turkey.
And that's why everyone is very cheerful after Christmas. Those who don't have family arguments, that is. Yes. Or yes, I wasn't going to avoid the alcohol. And that's why the Americans are always very, very, very cheerful after Thanksgiving. Everyone except the Donald, that is. Any further questions?
Is there any reason these days why you would do a splenectomy or why you wouldn't do one? If you've tried every other avenue of treatment, would it be a consideration or would you definitely not do it?
We have discussions with several people on this panel. I mean, my gut feeling is if nothing else works, why would a splenectomy work? It isn't going to work. No, I would always have an indium scan to see if my platelets were being taken up by my spleen. If the platelet scan showed that they were, then I'd quite happily have my spleen taken out because you don't have to worry about anything after that. If you've failed everything else, you won't have pure splenic uptake of your platelets. It just is not likely to happen. That's me being dogmatic. But yeah, the idea that of saying to a patient, well, we'll keep the splenectomy in reserve, we can always do it if anything else works, is fallacious nonsense.
My wife's personal experience is that after the splenectomy, no problems for about 8 years. And then, unfortunately, she had a relapse.
Well, if you have a good response to steroids and relapse, if you have a good response to IVG and relapse, and then you go and have your spleen out, you've got a better than average chance of having a long-term response to splenectomy. Those that are treated with the splenectomy as last resort, it's very unlikely to happen. We presented data here 2 or 3 years ago because we analysed the registry data that looked at results of splenectomy as you get older, and there's no doubt as you get older the responses to splenectomy are much worse, and I hope we'll publish that sometime in the next year. But certainly there is an age-related response and there is a treatment-related response.
I'm going to ask Dr. Kuta something.
Okay.
So some people say that splenectomy is the only truly curative therapy. Maybe it's not you. I don't know whether you say that or not. Okay. All right. Well, it's an American who says, so you'll do. So
just pick one of us off the street,
yeah,
okay?
Exactly. Who's American? Okay. But a lot of people do say it's the only curative therapy. But how often post-splenectomy, when the platelet count goes up, how often do they truly become antibody negative and the whole thing go away? I mean, really, is this just an appearance of a cure on a blood test, or is it a real cure, do you think? Because this person relapsed.
Well,
so
I don't think we know that answer, but I have patients who've had an antibody on their platelets before a splenectomy, and then afterwards the antibody has disappeared. And Mark Michel and their group have shown that the plasmablasts that are making antibody tend to disappear in this situation when they look at the spleen. So I think there's evidence there that the pathophysiology may be changed, but I have patients who had a splenectomy at age 8 and they had their ITP come back at age 80. I mean, I'm not saying I think it's
8 to 80.
Age 80. Age 80, yeah.
I mean, that of course could be just an underlying immune defect, and it's not the same disease. It's the same thing. But I think that's quite possibly the case. I think certainly in some forms of ITP, your autoantibody producing cells may be confined to your spleen. In other groups of patients, those antibody producing cells will creep out and sit somewhere else. Now,
they do. I mean, a lot of plasma cells
Yeah.
They don't sit around the spleen, they go into the lymph nodes. And so that doesn't get rid of them.
Okay.
So-
I just hate that term, the curative therapy.
Yeah. So once you've got cells producing
FYI.
autoantibody outside the spleen, at some stage or other, they will slowly increase and cause a relapse. And it's not something you can predict. And I'm not saying that an indium scan is 100% effective. Nothing ever is. But it's certainly 90% effective. Whereas if I just say to you, without checking anything else, I'm going to take the spleen out, I think the long-term results, irrespective of what you may have seen, are about 50%. But of course, what you have is 50% of people who now no longer have got their spleen in, who still need intensive therapy. And that's the issue of infection. Sorry, Cindy, I'm just banging on again.
No. I was just because, on the pediatric side, we do get consulted for neonates with maternal ITP. And even though the mother appears to be in a remissive state with a normal platelet count, the infant can still have. So I do think, to speak to your point about, for defining cure as antibody negative blood findings, we know that there are women that have had a splenectomy, have a normal platelet count, and the infant then still demonstrates a little bit of passive low-level antibodies. So.
Hematologists are very simplistic immunologists. I don't understand issues of B-cell development and epitope, antibody epitope specificities and how strong, and am I getting the words right here? And how specific they are and what levels you need for them. I don't understand any of that, so I'm just sort of extrapolating here. But I think what I'm saying is more or less true. But John, would you like to?
No, I mean, we've splenectomized mice that have ITP and have antibodies, and those antibodies don't go away.
Yeah.
It's because, again, the terminally differentiated plasma cells have left the spleen and they're now in the mesenteric nodes and in the axillary nodes and that. So they're out of the spleen now. So the splenectomy doesn't play a big role in reducing the antibody in mice, but David has got experience with patients.
Neonates and mice.
What reactivates the antibodies? If you've had a splenectomy, I had a splenectomy in 2000, and I have not got ITP now. I have a reasonable blood count. I do know that I'm not necessarily cured, that I do still have the antibodies, but what would it be that would reactivate those antibodies? Do you know? And,
no, but I mean, an infection could do it.
Sorry?
An infection could do it.
Any infection.
Well, a viral infection.
Yeah.
So when you define cure after splenectomy, what's your platelet count?
Oh, I don't know, because I haven't had a blood test for a long time. But I mean, when I did have one a while ago,
The reason I ask that question is many people have.
it was about 300.
Okay, we'll get it. Because some people have a splenectomy, their platelet count goes to 125,000, which is not normal, it's still lower, and you still have some, you're more compensated in some patients. But if your platelet count goes above normal, which yours closely is, then you probably have minimal residual disease based upon the fact your count is higher than the normal value beforehand. But some people, after splenectomy, the platelet count only goes to 150,000. We regard that as a cure, but it's still not a normal platelet count in someone who has no spleen. If I take Dr. Provan's spleen out, if his platelet count's 300,000 before that, after splenectomy, it'll be 450,000. So after post-splenectomy, platelet count is usually above normal.
Remember too that there is always the liver, and the liver can take over and destroy platelets as well as the spleen.
And it just needs something to stimulate these memory cells that he was talking about earlier, the soldiers coming over the horizon, that stimulates those to start producing. That could be almost anything. You may have a genetic susceptibility that if you get a virus or take a certain drug, or that stimulates them to go. So it's environment. It's as John was saying, there's a mix of genetics, environment, plus your immunology.
Or the privates take over, the macrophages and are activated. So for example, in a viral infection, if your platelet count's 100,000, you're in sort of remission, get a viral infection, your platelet counts plummet for a couple of days or a week, and then it comes back up again. That's probably because your destructive component from these macrophages, they're chewing up more because the virus said become more active. When the virus disappears, they become less active.
But I guess the splenectomies worked very well for you. Did you have any treatment before of the splenectomy? Did you have any treatment before the splenectomy?
What platelet count?
No. Did you have any other treatments?
Well, the treatment. Oh well, I had steroids, very high dose, about 120 milligrams, and for a while, and then I had IVIG at the same time, and then my platelet count. I went into hospital with a platelet count of 0, and it didn't go up above 8, so they decided to do splenectomy.
Okay. I think we've done splenectomy. It's all it's the macrophages. Any other questions?
Last chance to ask these famous experts why they're here.
We were discussing the problems of steroids, and I was quite keen to bring that out for this meeting as well. And I think Quinton summarised that quite well. And we were discussing the new guidelines of trying to reduce that. I guess it's hard to reduce it because they're cheap, and you take a tablet. But I think the increasing suggestion is that there are other options that are more expensive, that are potentially better. And I guess the issue is if starting more expensive treatments early reduces the overall costs, both financial and life costs, should we try to be pursuing that, or do you think we'll always have to have an element of trial and error with steroids before we get going? Because after all, a small percentage do respond to that. I mean, I think the paediatricians have the right idea, and I forget who it was who said earlier that we learnt a lot from the paediatricians in terms of how we handled ITP during COVID, of much more expectant, much more watch and wait, much less aggressive immune suppressive therapy. And I think that's been an important learning curve, and it's how we translate that to the regulatory authorities and the funders, that maybe there are other ways of looking at this than assailing patients with steroids at high doses. I mean, 120 for you, Rhonda, I suspect is 2 milligrams per kilogram, which is a phenomenal dose. You must have been up in the middle of the night hoovering the carpet.
Metaphorically, I used to do the night duty with the nurses. I couldn't sleep more than about 55 minutes.
Yes.
It was really terrible.
Yeah.
I mean, I just couldn't sleep at all.
The problem is, in terms of using something, say like a TPO or another drug up front, these patients often present accident emergency, out of hours, weekends. They're seen by the junior staff. And steroids is the easiest, isn't it then? It's very hard to organise something more exotic when it's a junior and you're at the end of a phone. I think that's often why steroids are started, I imagine.
But steroids could be the bridge. You get the platelet count up quickly, but you start something else rapidly as well.
Yep.
I think the question is, should we always have a period of steroids alone before we add something else in? I mean, we've not really done. We've sort of hinted at some of the studies, and small studies have been done adding things in. Do you think we have to have a period of pure steroids to see if we can achieve something there before? Do patients have to earn their more expensive therapies?
I said we've already admitted that the pediatricians are the higher brain of ITP. I've always asked this question sometimes of, in pediatrics, we do very, very short courses of corticosteroids, 5 to 7 days max, because we are bridging to what we believe is going to be spontaneous remission in children, right? So we know we just need this short course as a bridge. The longer courses in adults was always my understanding was to try to, maybe the fact that there isn't as much spontaneous remission, need to try to induce. It doesn't, seem as though that is actually highly effective in doing that. And we still end up with a lot of patients needing to go on to second line therapy. So to bridge the way we bridge to spontaneous remission, for you all to bridge to the appropriate agent, to me makes a lot of logical sense, just because that's how we practice. We use it as a short bridge to get to the outcome that we really want when we need to. So no. Let me back up here. When we need to do treatment, when there's not urgent bleeding that requires a prompt increase in the platelet count, if we need to do something, we usually will do a short course of corticosteroids, very, very short. I think I have done, to Drew's point, I have trained people at my center to understand that sometimes if we need to admit, but we don't always need to admit and begin treatment. So sometimes I admit so that I can come in the next day, see the patient, look at the blood under the microscope, talk to the family, have a good conversation. And so sometimes we can admit with the goal of just having that discussion the next day, not necessarily admit for treatment. Because I think that was why a lot of kids were getting admitted and getting IVIG, because there was a sense of, we're getting admitted and you need treatment, when really what they just needed was a hematologist. So we've taken that approach too. But I like this idea of kind of maybe, we use steroids very much as a short bridge. It's very fundamentally different how they're used.
Cindy, do you think...
It was George Buchanan, who spoke at these meetings very early on, used to make the point, which I thought was very, very good, that doing nothing doesn't mean you're not treating the patient.
Absolutely.
You don't have to
yes.
do something to show that you're doing it, because you're handling the patient, you're handling the parents, you're assessing the situation. It's not saying, I'll go away and come back if there's a problem. You are actually actively monitoring it, while at the same time not inflicting the potential side effects of treatment on someone who may not need it.
Cindy, I'm sure there's older data on this, but would steroid treatment, does it change the chronicity rate in the children?
So in children, we've never been able to really design a trial it's very difficult to design a prospective trial with chronicity as the endpoint, because it's so uncommon in children, which is why we did not choose that for our PINE study. We moved away from prevention of chronic disease. The IVIG study that was very nicely done, the randomized IVIG trial in children that randomized between IVIG and observation, and it was 100 children in each arm, showed no difference at 6 and 12 months. But again, chronic rates are so low in children that it's really hard to use that as an outcome to show a difference.
We suffered in adult therapy by the fact that we kept looking at what we were doing and analysing what we were doing. And the early TPO work, which said TPOs should be given for chronic disease, was developed at a time when we called chronic disease 6 months. And then the terminology was changed to call chronic disease at 12 months. And of course, the regulatory authorities seized on that, and on the funding authorities, certainly in the UK, and said, oh, chronic disease, that's 12 months. Forgetting that actually we'd made the decision when we'd considered chronic disease to be 6 months. And that's why we had that years-long struggle to try and get to use the TPOs early. And I think the COVID period, where we were able to use it if we wanted to as first line, which amply illustrated, we've seen several of the presentations today, that early treatment gets better results and probably better long-term results as well. And we need to try and push that, but I suspect it's not a battle that we will win easily. Fred, did you want to say something?
Yeah, I'm just wondering whether, steroids have a immunomodulatory effect as well. We know that lymphocytes have natural receptors to glucosteroids. So, wouldn't the addition of steroids with TPO give additional benefits to a treatment? This is coming from a theoretical perspective, of course.
Well, that's been my understanding of the long steroid courses, right?
Hasn't TPO and Dex been done?
Yes.
Yeah. That's
And it did work better.
good. Yeah, we mustn't chat amongst ourselves. We need to share it.
To be honest with you, if the thrombopoietic agents were free, everyone would be on it within a couple of days of the diagnosis. You might have prednisone or dexamethasone given for a week, as they do in the pediatric depression. To be honest with you, that's our current practice. We give people corticosteroids when they come in. We write the prescription for the oral agents, either eltrombopag or avatrombopag, and they start on day 3 or 4, and then are off their steroids. So that's our current approach. And it's I'm not saying it's right or wrong, and it's not based upon a huge amount of clinical data, but it works every time. The steroid exposure is virtually nil.
We would do that. We would do that if we could.
I think I think if we had the funding, that would be our preference. And I think we are waiting to see what some of the newer agents that David was talking about, the particularly immunological interventions. And I think we are extraordinarily lucky in hematology, because when you put an immunological intervention in, if it works, the platelet count goes up. So companies love us, which is why they want to use ITP along with one or two of the other antibody-mediated disease as their models, and it means we're an extraordinarily fortunate group that we do have access to these agents. And it'll be interesting to see if they do this sort of theoretical realigning the immune system and setting it back on an even keel and stimulating our Treg cells, because those are the sort of goals that we want. And I think although the TPOs will cause a longer term response off treatment, 6 months plus, it's still only 6 months plus. It may be much longer, but we're still looking at a disease that potentially will come back, as it does post-splenectomy sometimes. So it's looking at these immunological diseases. And I think it's a very fascinating era coming along. We take the immunological intervention and we lay under an infrared light, get our lasers into our bones.
Yeah, I think one of the things we haven't talked about at all is whether we can cure ITP.
Yes.
So again, this is a disease we've talked about. We don't talk about curing hypertension. That's never even a discussion. So I think right now we're in a situation where we have a disease which can treat for most people reasonably well, depending on what timelines our bureaucratic system lets us use. But we have not yet got a therapy that we can say, here's a drug that we'll take and you'll be cured.
But some of the TPO, people who come off TPOs, and I know we've had this discussion before, if you come off a TPO, you're on no therapy, you've got a normal platelet count, everything's all hunky-dory. I mean, 20 years, 30 years up the line, probably you can say you've been cured, but we'll have to wait a long, long time. Or do the basic science and work out what's going on in active disease and what state is it like immunologically now. It's very hard to say a cure for death, isn't it? And they may well relapse 20 years later. Fred?
A question. Do you think there's a role for CAR T therapy against B cells?
So CAR T therapy is a very interesting and novel therapy for a lot of malignancies where you actually use your immune system to attack the tumor, which is lymphoma. And there's a protocol with a CD19 CAR T cell, which actually will sort of wipe out your immune system better than the drug daratumumab. We're starting that trial right now, and we'll have our first patient enrolled on CAR T therapy sometime this year. This is for the really this is not for everybody. That's for damn sure. This is an expensive therapy, has complications to it, but it may be better than taking corticosteroids for 30 years or having a whole bunch of other procedures be done. So this is for the highly refractory patient.
How much does it cost, roughly?
It costs the patient nothing. It's on a clinical trial.
It costs the patient, roughly?
Yeah. So if approved, we're talking about $500,000 as yeah, I know. Yeah, well, we're now using
GPs can't order CAR T therapy.
Yeah. We're also now doing Yeah.
Well, we've got it coming in, but it's going to be difficult even for the malignant docs to get it, and for us, it's going to be. I mean, will we get maybe one a year? Maybe I don't even think we'll be paid for one a year.
Get that, to be honest. No, I don't. And I wouldn't be the first one to volunteer. Do we have any other questions? Actually, I intended to stop before then, but the discussion was really going on great guns, so we could take one or two more if anyone would like. Otherwise, I'll wrap up and thank the panel for a really stimulating discussion, and thank you all for staying the course. And I hope you all have a safe journey home, and let's hope next year is not bothered by COVID, lockdown, or Lynch. So, trains. Thank you very much for the panel, and thank you all. I think you'll all agree
oil.
This was a fantastic setup, and all the presentations will be on the YouTube channel or the website at some stage.